Okay. Okay. Yeah. Again, a zone 1, this material. Okay. Yeah. Sometimes we have a partial, supposing we have very distal replantation, sometimes we end up with having a chemical leaching, sometimes we do, and we end up with a partial successful replant. This again can be managed by adding other soft tissue. Sometimes we get patients who are late. They have undergone a fixation somewhere else, and they come to you with a near total gangrene, means the impending gangrene. So here, the important thing is, here only we have to restore the circulation. We are not supposed to do a vein, because means the dorsal skin is somewhere it is intact. So here means if the turgor is good, then you go ahead with the revascularization. This is okay. This is again a crush of the finger. Here a flow through flap has been done. A flow through, a venous flow through, because there is a soft tissue loss here. The flow through flap and the finger can be saved. There's again a cracker blast, loss of circulation in the finger, revascularized, and you can have a relatively useful function in the hand. Okay. This is again a sickle in this, and you can have a good functional outcome. There's a case where the distal tip replant has failed. It failed after a few days, and then a cross finger flap and a nail bed graft has been done, and you can see that the function is relatively okay. There's a multiple finger amputation in which the fingers are not fit for replantation. In these cases, if you say one of the fingers requires a soft tissue, which is the thumb, other fingers cannot be replanted. So we have done a pulp transfer from one of the amputated parts and covered the thumb. Non-replantable. Sometimes it's non-replantable. We can't do a replant. Then we do one of the procedures, GRF we do, where we put a bone graft and a cross finger flap, and we are able to achieve a decent function. This again is a multiple finger. Again, we have done a bone graft, nail bed graft, and you can see a relatively good functional outcome. Again, another case. So post-operative management, what is there for a replantation? You have to monitor the capillary fill, you have to see the color, and you have to see the Doppler. And what we normally do is we see the photographs by WhatsApp every few hours and make sure that the Doppler sounds are heard. And sometimes we connect the SpO2 monitor to the fingers, so it helps to monitor the finger regularly. And we pick up arterial thrombosis very early by keeping the SpO2 probe. The pediatric SpO2 probe is just kept to the finger, and we are able to monitor it properly. So that's thing. And if you have venous problems, they can happen because of dressings and splintage or tight closure. So if you have venous problem, first try to remove a few sutures, see that there's no compression around. And if you have a venous condition, then chemical leaching also is there, where we inject heparin into the finger and we allow the finger to bleed. And we are able to salvage a lot of fingers which do end up with venous congestion by doing a chemical leaching. Then sometimes we'll require a tenolysis for the fingers to improve the finger flexion. And then bone graft, sometimes we require to improve the bony union. If the bony fixation is not good or the bone has not united, then bone grafting is one of the common procedures which is done. And then as a conclusion, and it has to be done more means gently. The procedure has to be done gently, and it is not a very complicated procedure, but because you just require to restore the circulation and the venous drainage. They're the only two things. Artery has to give the supply to the finger, and the vein has to drain. Both, if they are done properly without tension, then it's not a very complicated one. But only thing is, because we often do it at odd times and we may not have good support, that makes it more strenuous. And then bone shortening is important, which is mandatory. if you give anticoagulants, it makes the post-operative period a little bit more messy, but it doesn't allow you to forget your anastomotic mistakes. So anastomosis is important. Whether you give anticoagulant or not, it doesn't make a difference. And strong tendon repair is very important. And I always felt that a stronger tendon repair is important because it will give you more functional outcome. And mid-lateral incisions are good, and redo is important and it's beneficial if it is done early. If you have a finger which is not doing well, you can go ahead, go inside and do the artery again, the vein again also, if the patient and the finances allow. Okay, and close follow-up is required in the post-operative period. Thank you.
Thank you so much, Dr. Jitendran. It was really enlightening. So we had one patient 2-3 weeks back. He had injury in the zone 1.
Okay.
But it was not total amputation. And so what we did is there was pinprick, slight blood flow on pinprick. So we passed a K-wire retrograde and then we did the suturing. Second day we saw that it was getting dusky. Okay. And in that situation, what would you advise?
See, when you have a finger which has been partially amputated, if you can restore the circulation in day 1, don't wait on the capillary bleed. If it is possible, repair the artery. Okay.
So can you just exit the screen so that we can?
Yeah. Just 1 second. How to do it? Yeah, once I stop share. Yeah. It's gone.
Right.
Yeah. So if you have a finger in which the circulation is not adequate, then it's better and important to restore the circulation. If you are planning not to do an arterial repair and just wait for the circulation to pick up on its own, then it's a dual-edged sword, because sometimes the circulation may not pick up and sometimes the circulation will pick up. If you are waiting for the circulation to pick up, then it's important to improve the venous drainage. You have to make a cut in the finger, allow it to keep bleeding, and give some heparin over that, so that it keeps bleeding and the arterial circulation improves.
Right.
Whatever the artery, because if it is subtotally cut, the venous drainage may not be adequate. The arterial supply also may not be adequate. So you may land with a dusky finger. So if you are not planning to do an arterial repair, then improve the venous drainage.
So all these finger amputations, what is your experience? How late can we do the replantation? I mean,
replantation usually, and we get patients around 12 to 14 hours later. That's a usual time. So that and all, it's quite often. Sometimes one of the patients was 1 year old. He came at night. He had an injury at 6:30 p.m. He came at night around 9. He didn't decide for replantation till 11. Then we kept the part in the fridge. We came in the morning. Still, they were not decided for the replantation. So we dissected the part in the morning. And we felt that the part is fit for replantation. So we told the patient. And by around 10:30, 11, they decided that, okay, you can try. So once we did it,
almost 24 hours.
No, not 24 hours. It's more than 12 hours.
Okay.
14 to 17 hours. So that's the usual time. Many other patients, they travel a long distance and then they come. So 14 hours, 15 hours, 18 hours, 20 hours is fine.
Fine.
As long as the part is fine.
This is for the digits. What about a wrist level, a forearm level, an elbow level? What would you suggest? I mean,
a wrist level, you can easily do it around 20 hours also you can do, if the part is preserved.
But when muscles are involved, like forearm, mid forearm, or
as you go proximally, and your time gets less. But if it is distal, it's fine. Forearm and arm we have done till 12 hours, but that doesn't give a great outcome. A muscle go into VIC. If it's a forearm level, most of the muscles can be debulked in the forearm. So then also you can get around it. But as you go into the arm, the forearm muscles are still there. So I mean, they go into VIC if they come late. But the hand survives.
True. So any questions to Dr. Jitendran? So thank you, Dr. Jitendran. That was a wonderful presentation. So you had shown 2,3G graft reposition on flap.
Yeah.
So our next speaker is the originator of that
Yes.
graft reposition on flap.
Yeah.
So I invite Dr. Vijay Malshikhare. So he's a hand surgeon from Pune. Even though his topic is not graft reposition on flap today, so I invite him for PIP injuries. Dr. Vijay.
Thank you. My skin is visible.
Yeah.
Yeah. So this is a recorded version of PIP fracture dislocation of Suzuki frame. Just I will play the video.
No, it is not.
Dr. Vijay, your sound is,
Sound is not there.
Yeah.
1 second. Is now coming?
Now we can see that video, but is there any background sound? Are you speaking with that?
Okay, 1 second. No, 1 second. 1 second. 1 second. 1 second. 1 second. I think I have to unmute my sound.
That one, right. Dr. Vijay, still we are not able to hear if there is any background.
Hello?
What's
the problem?
So I can hear you, but I am
Mhm.
not able to, I am able to see your video also, but I'm not able to hear anything from that video.
Sir, while sharing this video, click on that share sound also.
Share sound also. Okay, where is sharing sound? Please.
The share screen, there is an option below in the left bottom, share sound. Just click on that.
Where it is? 1 second. Where is it?
Open the
विजय
Zoom.
तुम्ही बाहेर
and-
पडा सगळ्या ह्याच्यातनं आणि पुन्हा एकदा शेअर स्क्रीन करा. शेअर स्क्रीनच्या खाली शेअर साऊंड म्हणून असतं.
बरं, 1 मिनिट. आता परत शेअर करू का?
शेअर.
आता हे शेअर केलं मी. ओके, तर त्याच्यामध्ये शेअर आलंय. अजून शेअर विथ साऊंड. आहे शेअर साऊंड. ओके.
Hi, I am
आता येते का?
Dhirendran Mahida. I am from Pune.
येते?
PIP injuries are
Yes,
the
sir. Yes.
injuries.
Okay.
So often, PIP joint fracture dislocation considered as a nightmare for orthopedic surgeon. So today's talk will convert this nightmare into the bliss dream. And this bliss dream is Suzuki frame.
Suzuki frame appear to have gained popularity because of the simple in use and easy to reproduce in others' hand with same outcome. Several other groups have subsequently published their experience of its use, surgical technique and inventory required. For this procedure, we required 1 mm or 1.2 mm 9-inch K wire. It should be checked for ahead of time because many surgical centers stock only 6-inch K wires, 2 1 mm 6-inch K wires, 2 rubber band. If a long 9-inch K wire is not available, then we can use 6.5 cc screw guide wire. 55-year-old male patient came with history of cricket ball injury 1 day back. X-ray showed fracture dislocation of middle finger, and this is the pre-op movement. We prefer flexor sheath block by using bupivacaine and lignocaine 10 ml so that patient can move the finger after the surgery. First of all, we mark the center of rotation of the proximal phalanx under Shyam by using K wire. Once it is confirmed, then we mark with a marker pen. The same step is repeated on the middle phalanx and mark with a marker pen. Then we draw the line between 2 points, which should be a straight line. Then we pass a 9-inch 1 mm K wire from the center of the rotation of proximal phalanx under Shyam. Now this wire is now called as axial K wire, which is confirmed under Shyam, and in lateral X-ray it should look like a dot in the center of the rotation. This will not abut the transverse retroculateral ligament. Then we hold the K wire with a needle holder and bend to the 90-degree by a suction cannula, and other side is bent and take it away from the fracture site. Then 6-inch 1 mm K wire is inserted from the center of the rotation of middle phalanx under Shyam. Now this wire is called as hook wire. Then we bend this K wire to the 90-degree, one end, then other end by suction cannula, and this cannula is a very beautiful instrument for the bending of the K wire. Then 6-inch 1 mm K wire is inserted in the metaphysis of the middle phalanx, which is called as the reduction wire, which is important wire which prevents the dorsal subluxation of the middle phalanx. If you see, the reduction wire is volar to the axial wire, so that in extension axial wire presses onto the reduction wire, and that prevents the dorsal subluxation. We bend it, this wire, on the axial K wire. Then making of the hook. Distal hook is made with the help of needle holder and suction cannula. Final adjustment in the shape is done by a nose plier, and remaining wire is cut by a K wire cutter. Same U hook on other side. From the hook pin, we measure 3 cm distance on the axial K wire, which is shown in the picture. Then on the marking, needle holder is applied and wire is bent inside with the help of K wire bender. This is the first bending. Then with the nose plier, then more bending is done. Then wire is stabilized, and then second bending is done by using a suction cannula. This hooking of the proximal wire is very difficult and it needs a practice. Finally, we bend the wire with a nose plier to form a S-shaped hook. Other side, same 3 cm marking is done for hooking. If you see, the level is same. So finally 2.5 cm is the ideal distance between two hook.
We use IV latex rubber as a rubber band. 1 mm is the ideal size of the rubber band.
We mark 1 millimeter on the rubber. We cut 1 millimeter slice and use this rubber as a rubber traction unit between the two hooks. This is very stiff rubber and never gives you distraction in the joint. I prefer over dental rubber. This is the final frame, and this is the on table movement of the patient.
If frame shows flight takeoff sign, then your frame is biomechanically correct.
In post-op lateral view X-ray, the joint is reduced and there is no subluxation dorsally, and in AP view, the joint space is maintained.
And in post-op, 1 week, no movement till pain subside. After that, start active mobilization every 2 hourly. Wire removal after 1 month. Start vigorous physio after that. Night sprinting and full range motion after 3 months.
Case number 1, Bollywood makeup artist, cricket ball injury, PIP fracture dislocation, which is highly comminuted and joint is severely subluxated. After Suzuki frame application, joint is reduced, seen in X-ray. This is the result after 3 years. Patient has got full range of motion in spite of central depression. On lateral X-ray, there is no arthritis and joint is fully congruent. But after 5 years, we have seen that patient has full range of motion, but on X-ray that central depression has removed nicely and no subluxation of the joint, and there is no arthritis visible on the X-ray. This is second patient, cricket ball injury, young adult. X-ray showed PIP fracture dislocation with subluxation of joint and Suzuki frame was done. This is the 1 year result. Patient has got full range of motion. There is no flexion contracture or extension lag. On X-ray there is no arthritis, joint is congruent and there is no subluxation seen on X-ray. Again, case number 3, same cricket ball injury, young adult. There is a pylon fracture with dorsal subluxation. Usually in pylon fracture we don't use reduction wire, but here the subluxation was dorsal, so we added reduction wire. 1 year result, patient has got full range of motion. There is no extension lag or flexion contracture and joint is reduced and congruent on X-ray. Last case, again cricket ball injury. In India, cricket ball injury is the commonest mode of injury for PIP fracture dislocation. Joint is subluxated and Suzuki frame was done. This is the result after 1.5 years. If you see, patient has got an excellent result. On X-ray, joint is congruent in flexion and in extension, and patient doesn't have any problem and ready to play. In conclusion, Suzuki frame is more compact and comfortable. It will give good result if we don't violate principle and technique of original author, and this is a very important take home message. And thank you very much. Hello.
Yeah. Yeah, Dr. Vijay, very nice presentation, very nice video presentation and good X-rays shown. So, if the patient presents late, let's say 6 weeks, 1 month, do you advise to do this procedure?
Yes, because what happened, if it is a 1 month, usually what I do, I anesthetize the finger and do the harsh manipulation. So I create the fracture again. And then I do Suzuki frame. So this will give a not an excellent result, but acceptable range of motion.
But then if there is no, if you try to manipulate and there is no movement, or you are not able to, till what time? Say 6 weeks, 2 months, 2.5 months.
See, one patient I had did 40 days, only one patient. But usually 1 month is okay. And one patient I did for 40 days. And she has got a good range of motion. She's okay with that. She doesn't want a full range of motion, but she was okay. So if you get away from the situation and we explain the patient, if you want a full range motion, you have to do a hemi-hamet or other procedure. But if you are acceptable, good range of motion, then you can try for a Suzuki frame. And if the patient opts for a Suzuki frame, then I just manipulate it very harshly to break this adhesions and fracture. And if on manipulation, if I get a full flexion and full extension passively, then I will do Suzuki frame. Otherwise, no.
Do you recommend this procedure on day 1? Because many times they say that Zimmer static dynamic splint would help. So day 1, do you recommend?
In which type of fracture?
Like what examples you have shown a fracture dislocation PIP joint.
Okay, so see, in conservative treatment, it is not sure that in India, the patient compliance is very bad. So if you go for a Zimmer splint, and if he develop a flexion contracture, then it's a problem. But this procedure under digital block, you have to put only 3K wires. It's no harm. And day 1, we can start the mobilization. So you can assure the patient that you can get a good range of motion. By giving a conservative, treating with conservative treatment, there's always a chance of stiffness. So because all patients are, not all patients are from same city, they are from other part also. So the physiotherapy compliance is very bad. So I prefer Suzuki frame because it is very easy. Under local, you can put a 3K wires and that's it.
So the new thing what I saw today is that the center of rotation for this and the line should be in the both point should have one single line. So what is the importance of that? I mean, I have seen for the first time.
Because basically what happened, it was criticized because proximal wire, all other people were saying that it is going through the center tendon or ligaments, everything. So that's why I demonstrated if it is the center of rotation, then this transverse oblique ligament, it is just distal to that center point. So it is not abutting the transverse retroculavicular ligament. So that means the range of motion will not affect you. If it is not in center of rotation and it goes through the transverse retroculavicular ligament, then there will be the extension lag. So the main thing is, that's why in last slide, I have mentioned that don't violate the principle of original author, because he has spent many years to developing this system. And we have don't right to modify this thing. So basic principle will not change at all. So my home, because all are fascinated about a Suzuki frame, all are fascinated. Suzuki frame, but if it is done correctly, it will give a very good result. If it is not done properly, then there is a lot of complications, extension lag, cutout wires, over distraction, and people say, oh, no, this is not helping us. So my simple take is that don't violate the principle of original author. Wire should be at the center of rotation all the time, not dorsally, not volarly, not proximal, not distal. It should be bang center.
Right. Thank you. Any other questions to Dr. Vijay? Right. Thank you, Dr. Vijay, for your excellent video demonstration.
Thank you very much.
Yeah. So we move on further. There is a slight change. So I would request Dr. Samrat, we'll take your thing next because Dr. Amit has to go somewhere. So I request Dr. Amit Varade. He is a hand surgeon from Nasik. Excellent scaphoid presentations he has. So I invite Dr. Amit for his presentation on scaphoid.
Yeah, thanks. Yeah, can you see my screen?
Yes, Amit.
Yeah. First of all, I would like to thank Indian Orthopaedic Association and Dr. Ashok and Dr. Abhijit for giving this opportunity. I'll be talking on acute scaphoid fracture treatment algorithm. So scaphoid fracture is most common fracture of the wrist joint. And we all know that it occurs due to fall and outstretched hand. But there is one word for scaphoid, that scaphoid is a problematic bone. Why we see? See, if you see the anatomy of the scaphoid, it is like a twisted cashew. That's why it is difficult to image, interpret, and fix. So there are some other factors also which are responsible for this problematic bone not uniting. These are like, it has a very small amount of periosteum, and it is a totally intra-articular fracture, and synovial fluid continuously ingresses into the joint, and which dilutes the osteoblastic cells, and it hampers the callus formation, and there is no union of the scaphoid. Then if we see the fracture poles, proximal pole lie along the proximal carpal row, distal pole lies along the distal carpal row, and there occurs shearing forces across the fracture site when there is flexion and extension. And this is also one of the reasons why it is not uniting. Then if you see the capsuloligamentous attachments around the scaphoid, it is such that in case of fracture, it has a tendency to flex, and lunate extends, and it develops DZ type of deformity, and it is instability of the wrist. So another factor which is worrisome is the impaired vascularity. We all know that scaphoid has a very precarious blood supply, and it goes from distal to proximal. And as we go from distal to proximal, the blood supply also decreases. See all this and displacement. This is also one of the factor. So due to all these problems, there is a problem in union of the scaphoid. So we need to address all these things. So before going to management, we'll see the clinical presentation of the patients. These patients generally present with pain in anatomical snub box. And this is another test, which is scaphoid compression test. Here you have to hold the first metacarpal and press it against the trapezium and ultimately on the scaphoid. There will be pain on compression. So when there is a snub box tenderness and scaphoid tubercle tenderness, it is 100% sensitive, but only 20% specific. If we add specific the compression test, then the specificity reaches around 74%. So whenever we have to order X-rays, we should order this subset of X-rays, which is PA view in ulnar deviation, lateral view, pronated oblique view, and this is oblong view. So we'll see how we have to take the proper views. So proper method of taking PA view is shoulder should be abducted 90 degree, elbow should be flexed 90 degree, and hand should be rested on the X-ray cassette, and beam should be projected from the dorsal aspect. So this is the proper position of PA view. And lateral view, the shoulder should be adducted, elbow should be flexed 90 degree, and this will give the proper lateral view. There is SPC lateral, scaphoid, pisiform, and capitate. All these things will lie in one plane. And this is the ulnar deviation view. We also have to do pronated oblique view and supinated oblique view. It is in between the mid position and pronation and supination position. So these views, these 6 views, which is PA view, lateral view, PA view and ulnar deviation, and pronated and supinated oblique view, increases sensitivity and specificity to almost 100%. So whenever we come to management, whether we have to conserve it or we have to operate it. So the question comes, what is the treatment algorithm for these acute scaphoid fractures? So if we go back to Herbert's classification, this classification is based on three things: site of the fracture, duration since injury, and treatment guidelines. So if we see the literature, according to this study, percutaneous cannulated screw fixation of non-displaced scaphoid fractures resulted in faster radiographic union. But according to this another meta-analysis, they say surgery significantly increases the risk of complication, and aggressive conservative management should be the mainstay for scaphoid waist fractures. This is about only waist fractures. So then again, another study by Professor Joe Dias, he said displaced fractures of the scaphoid have 4 times higher risk of non-union than undisplaced fractures when treated in a plaster cast. So I think there is no doubt that displaced fractures should be fixed. So according to this paper. So then another landmark study by Professor Sunil Tirkanan, when he came to Mumbai for ISSH, he has shown this. He said he did study for particularly undisplaced fractures, and he has managed some patients conservatively and operatively by percutaneous screw fixation. The conservatively treated patients have union rate of 76%, and acute scaphoid fractures treated surgically, union rate is 95%. So again, we will go back to the fracture healing. There are two things. One is biological and biomechanical. So biological means blood supply. So we all know the blood supply we have just discussed. The another factor, biological factor, is that fracture is intra-articular, which we cannot change. So another biomechanical factor is the radioscaphocapitate ligament, which acts as a pivot around the scaphoid when it moves in radial and ulnar direction. So we cannot change that. Now, as we have discussed, due to the capsuloligamentous attachments, whenever there is scaphoid fracture, there is a tendency to flex, and there is development of humpback deformity. So now we have to tackle all these fractures. And when we choose a treatment modality, there should be some predictability of the outcome, and predictability of and there should be some factors which we can control. So blood supply, we can get back new blood supply by vascularized bone grafting, by doing surgery. And since it is intra-articular fracture, we can give rigid compression fixation, because we all know that scaphoid gets union with the help by the Haversian method of remodeling, and it can be achieved by putting a screw. And we have to prevent the development of classic humpback deformity. It can be done by fixation, either by screws or by K-wires. So now next question is K-wires or screws. So basic things which we have to keep in mind, that whatever implant we are using, it should prevent rotation, it should prevent bending, it preserve articular surface, and promote endosteal healing. So if you put a single K-wire, then it will prevent the bending and preserve the articular surface, but it will not prevent rotation, and it will not promote the healing. If we add one more K-wire, then rotation can be taken care of, but not the endosteal healing. If we add screw, we'll get all the factors. It will promote endosteal healing. Here it is wrong. It will not prevent rotation. We have to add one more wire, then it will prevent rotation. So whenever we want to approach the scaphoid, which approach we should take? So just see what is the fracture, whether it is a proximal pole fracture or waist and distal pole fracture. If it is a proximal pole fracture, then dorsal approach, and for waist and distal pole, volar approach. However, we can approach both the poles with the help of volar approach also. It also depends on the surgeon's choice. This we'll see example. This young patient presented with waist fracture, say acute fractures of 7 days old. So we treated it with percutaneous Herbert screw fixation. And one trick I want to tell here, we use 16 number needle for passing guide wire from the scaphoid. It will help prevent bending of the wire, and it will give direction to the wire. And this is the PI and lateral view, nicely compressed fracture. And Another, and this is the 2-month result, scaphoid united. We can see in PA in lateral view. Another patient, proximal pole fracture. We treated it with arthroscopic assisted scaphoid fixation. Advantage of arthroscopic fixation is we can see the radiocarpal joint, we can see the screw length, we can see the articular surface after putting screw, we can see the reduction, we can assist in reduction. So these are the images after passing wire and images after putting the screw. And 8 weeks after, it united nicely. And it has got reasonably good range of movement at the wrist joint, flexion, extension. So, basic question of treatment algorithm. Whenever we see scaphoid fracture, then if it is undisplaced, non-operatively, we can treat it with cast. But if it is displaced, we have to fix it with screw or K-wire. But the most important thing, we have to tell patient that union rate is 76% only if we treat it in cast, and in surgically it is 95%. Thanks a lot for patient hearing.
Thank you so much, Dr. Amit. So many times we get a patient with pain in the anatomical snuff box. If we take an X-ray, there is nothing you can see on X-ray. And in those cases, do you advise a scan?
Yes, first.
So when do you advise a scan? I mean, in this fracture.
This is a very common situation which you have elaborated, which we see every day in our practice. So first, most important thing is clinical examination. Along with the scaphoid fossa tenderness, anatomical snuff box tenderness, you also have to do compression test by pushing the metacarpal. If it is also positive, then think that there are high chances of scaphoid fracture. Then just put a scaphoid slab to the, just do scaphoid slab to the patient and call him after 8 days and repeat the X-ray. And you will find a gap at the fracture side a lot of times.
When do you ask for a scan to confirm the diagnosis, or you feel that there is, in a later stage, there is some avascular changes?
Yeah. After 8 days, you have to repeat X-ray. And on that X-ray, if we see fracture line, then it is okay. If we are not seeing the fracture line, then we have to go for further examinations. We can, that time we can ask.
Right. And what is a scaphoid slab? Can you just show?
Yeah, we have to keep the IP joint of the thumb free in a glass holding position.
Right. So it is basically on the radial post.
Yeah, radial side, and we should keep the IP joint free.
Great. Thank you, Dr. Amit. Any other questions to Dr. Amit? Right. Thank you so much. Yeah.
Thanks.
So, so I request further, we'll move on. I request Dr. Samrat. So he will be speaking on fracture first metacarpal base. Dr. Samrat is a hand surgeon from Nagpur, and I request him to please share the screen.
Good evening, everyone. Is my screen visible? Am I audible?
Yes.
Okay. I thank the West Zone IOA, Dr. Shinde, Dr. Abhijit Mahida sir, Dr. Ashok for giving this opportunity. We had very excellent presentations till now with a lot of tips and how the things can be done. My presentation is more of case-based. It's a varied surgical experience of the fracture of the first metacarpal. And this is a case series presentation, and it does not cover the topic as a whole and every fracture or every treatment option. Some figures have been taken from internet, from the AO educational material. All cases were done by us. So worst metacarpal fractures can be Bennett's, chronic Bennett, non-union, or Bennett fracture with trapezium, Rolando fracture with a further distal combination, or a shaft fracture, which is simple or with combination, and compound fractures. So please tell me when to stop. A lot of cases are there. A few anatomical consideration why first metacarpal fracture to be discussed. One is about the anatomy. So it's a saddle shaped joint and the surface is markedly convex on the flexion extension plane. So that is one reason where we get why we get a subluxation in Bennett's. We come to it. Now this joint, the first carpometacarpal joint, is very well held with capsular ligaments. Three more important ones are on the volar side, and we know that the most important is on the volar ulnar side, which we call the beak ligament. Three muscles are attached to the base: flexor pollicis brevis, abductor pollicis longus, and apponens pollicis, and they form the deforming forces. So Bennett's fracture is classic. My talk, I want to stress on the point that when we see a fracture, we look at the deforming forces, maybe the muscles or maybe the capsular attachment of the fragments, which can be then used for the reduction. So that's all this whole presentation is. So in Bennett's fracture, we know that there's an axial overload along the first metacarpal with a simultaneous flexion of that thumb, and the deforming forces are the adductor muscle here, which are going to adduct and partly supinate the distal metacarpal fragment, and the abductor pollicis longus, which is going to pull it. Why? Because as such, abductor pollicis longus abducts the thumb away from the palm in the radial aspect, but that is when it uses the volar beak ligament as a fulcrum. So now, because the volar beak ligament and a marginal fragment attached to it is fractured here, and it remains with the hand, the abductor pollicis longus literally causes the proximal migration of the metacarpal. Before we move further, Rolando fracture, described in 1910, is a three-part intra-articular fracture, and it can be T or Y shaped in sagittal or in the coronal frame. And multifragmentary intra-articular fractures of the metacarpal base are nowadays also called as Rolando, but they are a bit different. And in Rolando fracture, traction X-ray or CT scan works is required. Coming back, so this has been described, and the reduction maneuver is exactly the same for Bennett's fracture. Under anesthesia, we give a longitudinal traction. We press the base of the first metacarpal for the reduction. At the same time, we pronate the thumb. So the supinated distal part is pronated to give the reduction, and this subluxated part is pressed towards the fragment to give reduction. And it is fixed. There are ways to fix it. Generally, people prefer this method where they put one wire through the fragment and another through the trapezium, or the other way is that one wire through the fragment and the other through the second metacarpal. If the fragment is large, if it is an old fracture, then we can do open reduction and internal fixation. Just a word of caution that these are the branches of the superficial radial nerve, which can cause a very painful neuroma, and they have to be seen not just when we do open reduction, but also when we are doing K wiring for Bennett's fracture, Rolando fracture, or any fracture of the metacarpal of the thumb. First example, this is a classical Bennett's fracture, and it was fixed this way. And patient did extremely well. My whole concentration was on the fact that the joint is reduced and the fragments are approximated. It was a close reduction. This is the second one. Again, here one wire is to the trapezium, another is to the second metacarpal, and there is distraction which should not be done. But the patient did well. But if I get such a case again, I would remove the wire and avoid this distraction to happen. This patient did fairly well. Removal of the wire at the 6 weeks. This is our now regular protocol. We put one wire through the first metacarpal to the fragment that is on the volar aspect, that's a Bennett fragment, and another wire through the first to the second metacarpal. It is technically, uh, uh, it has a learning curve, small learning curve, but it has to be done. And you can definitely see that there were 2 attempts first of putting a wire there, and I was not very happy about it. And then I used this wire. So it has a learning curve. This is again the example of the same technique, one in the Bennett's fragment, that is the volar fragment, and another in the second metacarpal. And they do very well. So what about a 2-month-old? In this case, we had to do a open reduction internal fixation, and the method used was a Wagner's approach. We know the Wagner's, I'm sorry. So the Wagner's approach, which is taken between the dorsal skin and the volar skin through the thenar region, and then it is the incision is bit put on the ulnar aspect here, and we raise all the thenar muscles, expose the capsule of the carpometacarpal joint, and then we are at this particular level. So in a Wagner approach, this patient, we open the fracture, and then we use the inside out technique. We debrided the fracture site here, and then first we drilled the screw wire from inside out, and then fix it with rubber screw. Similar case, this was not reduced even after reduction, so the joint was a bit better, but the fracture was not reduced, open. And what we see here is this is the Bennett's fragment. This is the rest of the metacarpal, and see, it is in a supinate position. That's why the joint is open. And when we pronate, the joint is fixed. Again, we use the inside out. We put a wire through this, coming out from the dorsum skin. From the dorsum skin when it's come, and then we reduce it, and then fix it this way. So these wires are threaded K wires, and deliberately we use it to fix the fragments. This is the case. We now go towards the metacarpal shaft fragment, or we can say comminuted Rolando type. And this was openly reduced, and it was very difficult to fix because of this volar fragment, which we could not hold. The ideal would be to use again a lag screw for this, which was not available. And fortunately for me, the patient has done extremely well, even with this type of fixation. Given a choice, next time, thanks to Dr. Hemant Patankar sir, what he described recently was he would use an extension block wire. So he would put a wire like this, and that will definitely give me a better reduction. This subluxation which we see here won't be there. The subluxation which we see here won't be there. So that would be the next time if I get this case. But fortunately, this patient has done extremely well. This is 2-year follow-up. Comminuted fracture, open reduction, internal fixation. So we look at the fragment, and then we look what is attached to what. So we know ligaments, some ligaments are attached to this fragment. This fragment probably is loose lying, or it is attached to the capsule here. And then this particular whole fragment is a bit adducted, it is supinated. So Wagner's approach, open reduction. Once we opened it, again we went from inside out and then fix it. And for the insurance, so that we are ensured that patient gets a better result, we put an external fixator. Fixator was removed at 4 weeks, and the wires were removed at 6 weeks. Patient is doing extremely well. This is old Bennett, and I skipped this video. Basically, we use a flexor carpal radialis. So what was done was that this patient had a old Bennett's fracture and a whole subluxation of the first metacarpal. And after reduction, there was nothing. We were not sure that these 2 KYs are going to hold anything. So we use the ligament reconstruction method, which we use for the CMC joint arthritis. We use a flexor carpi radialis hemitendon, and then reconstructed the volar beak ligament, stabilized it with 2 KYs. This is his final picture, 16 months post-op, and patient has got excellently very good results, except for a neuroma in this area, or maybe a sensitive scar in this area. Finally, these fractures can be associated with other fractures like here. So we have a metacarpal fracture, scaphoid fracture, and a distal radius fracture. And first, the protocol is to first fix the radius, the scaphoid, then the radius, and then the first metacarpal was fixed. Here we fixed, again we opened a reduction and done, and we fixed piece by piece using whatever attachment it had. You can see that I have ignored this particular volar fragment. Otherwise, each fragment was with the attachment, with its capsular attachment and a muscle insertion was used to fix this particular position. And on table, this articular surface was quite congruent, less than 1 millimeter of step was there. This patient is a medical student. This is his post-op X-ray after 6 months, and he has done extremely well in terms of scaphoid, radius, as well as in the first metacarpal fracture. Finally, bilateral injury with a Galeazzi, with tibia, etc. So comminuted fracture this way, traction, and we could reduce it and just fix it with K wires in various directions. And this is 6 months post-op. The fracture has reduced. There is a bit of flexion at the metacarpal base region, but otherwise the patient, the base of the first metacarpal looks good. This is the opposite side. He had a comminuted fracture of the head of the metacarpal, and here I used a combination. First, I used a bouquet technique to just get a hold of that, so that it just goes and reduces. Then I used this K wire because of a fragment which I could hold and fix it this way. And then I used an external fixator to stabilize it. This is the final picture, and patient followed up very well. And this is his left side, which was fixed with multiple K wires, closed. And this is right side, again fixed with external fixator and bouquet technique and K wire, closed. Finally, about extra-articular fracture of the base of the first metacarpal, they fracture with a flexion deformity and a palmar comminution. I don't have a picture of that, but so such a situation where there was a flexion deformity and a palmar comminution is there, and this patient particularly had a conservative management, but there was no reduction, was lost, and then we use a plate for it. Very rarely we have to use a plate, at least for open, for acute cases we don't require. So this is another case where he had a fracture here, and it was just well reduced and fixed with 2 K wires. 1 K wire I deliberately went through the trapezium to get a better hold. And this is the example of a plate. And this is 3-month post-surgery, and patient has got extremely good movements. So a bit about the plate. So the one is about the comminution, which has to take care about. Second is that the plate at the base has to be bent just a little, so that the screws don't go into the joint. And third is that reduction by plate, but I think fragments are very at times very comminuted. Reduction by plate may not be very easy to do. Also, that if we attempt a lot of compression, attempt compression here, then we may get into a problem because this side is comminuted. I thank you, and I invite suggestions because this is case based. So any suggestion for any case would be welcome, sir.
Thank you, Dr. Samrat. Can you stop the screen sharing?
Yes, sir.
Yeah, so excellent presentation, excellent case-based presentation. So I have seen in couple of cases you have put in an external fixator. So that is the duration of external fixator and why an external fixator is required.
Absolute rigid fixation can be achieved only through plate and screws. Otherwise, for K wires, with such of deforming forces, probably after fixation, initial X-ray looks nice and then there can be a collapse. In those cases, I have used external fixator. Also, in one situation where the patient had a bilateral thumb injury, there I used it for a distraction to keep it, because the comminution was in the metacarpal region, in the metaphyseal region. So there I used it for distraction. And in one case where it was comminution at the base, it was used to so that it does not collapse.
Right. And So many times what we do is we pass a K wire from the base of first metacarpal into the trapezium, one K wire from base into the second base of metacarpal. So is there in a protocol in which you remove these wires?
No, we remove the wires at the same time. Both the
Same time.
wires are removed at 6 weeks. Yes.
Right. And one new thing what you told is that abduction blockings K wire to read
Yeah.
to for the subluxation to be reduced. So how often this has been done? I mean,
So this is a very personal communication with Patankar sir, and he has been using it a bit. And
no, it's a
we
very
hope
good
that he
idea.
comes.
That's why I'm asking.
So,
It's a very
yes, so we hope that sir comes and comes out with a publication soon. I have asked him to publish so that we know the guidelines and other things.
Vijay sir. Any comment
So,
on
yes,
abduction blocks pinning in Bennett's fracture?
at least even if we don't require it in Bennett's, I think it is required in such comminuted fractures where we have a fragment which is subluxating and does not have a hold. So there it will be of great use, I think.
Yes, Vijay sir. Any comments? Unmute.
Unmute.
I think it speaks the experience. It's
Right.
all about the
Yeah,
experience. Hello?
Yes.
Can you hear me?
Yes.
Yeah, I'm saying that it's the experience, nothing else. And it's a very nice trick. Just we have to pass the K wire and just block the subluxation. So I
The
think
way
it's a very good
we
trick.
do in a mallet. The way
Mallet,
we do
yes. Because the principles are the same. Everywhere principles are same, but where to apply is the question. Whether you apply on mallet finger or in this situation or in Kapanji, all are blocking wires, but the principles are same. The situations are different.
Right. So great, Dr. Samrat. It was an excellent presentation. Thank you so much for a case-based presentation. So from base of first metacarpal, we move on to the fifth metacarpal. So is my screen visible?
Yes.
Samrat? Yeah.
Yes, sir, it is visible. Yeah, yes, definitely.
Thank you. So this is basically for the fracture of fifth metacarpal. So fondly called as a boxer's fracture. So it is said that it's a misnomer, never seen in professional boxers. Clinically, there is loss of prominence of the metacarpal head, palpable metacarpal head in the palm, and rotation of the digits. So sometimes this can be seen. So the prominence is lost. So this is the way it presents. And we see 2-3 things in these fractures. One is we compare the length on the opposite normal side also. Then we see for the rotation if there is any scissoring. And so basically fifth metacarpal, fourth and fifth CMC joint, metacarpophalangeal joint, there is 30 degree of extra motion. So this is utilized to compensate for 30 to 70 degree of flexion of metacarpal head. So that is why it is said that even if there is a angulation of less than 70, we can conserve it. So the anatomical fact is relatively high degree of motion of fifth CMC joint, carpometacarpal joint, can tolerate a marked angulation in AP anteroposterior plane. So that is why several authors have reported functional results can be achieved with little or no correction of these fractures in the AP plane. So what this is an X-ray which is advised. So this is a view in which we can see, and the treatment part is either conservative or surgical. So a closed method is preferred. Some in surgical, percutaneous or ORIF, or a plate. On conservative, there is manipulation, flex fracture is relocated fracture is derotated. So something like this. This is a jazz maneuver where we use the tip of the injured digit and try and get the reduction. Now this jazz maneuver is not done nowadays. So this is the way we do a PIP joint extension, and then we give direct volar pressure so that the fracture is reduced. So this is the way. Then the PIP joint is flexed, and we can see these are the conservative methods. So this jazz maneuver is abandoned because there is a lot of PIP stiffness. So keeping the finger like this in a immobilization will get stiffness, skin complications, recurrence of deformity. So there are various methods of immobilization. One is this extension cast with 3-point mold. So this is the way. Second is outrigger splint and ulnar gutter splint. So this is the best, and so this is the thing what we follow. We give a dorsal slab and a volar slab till the first metacarpal crease, so that will maintain. So in this comparative study, there was seen that there is no functional difference, and many times there is a collapse seen at 3 weeks. So absolute indication for surgery in a Oxus fracture, if the angulation is more than 70 in a lateral X-ray or in an oblique X-ray, then if there is a rotation of the fragment, fracture in the 5th ray, and open fracture or pseudocloying. So these are the absolute indications, and many times it can be treated conservatively if the angulation is less than 70 degrees. So various methods. So these are 2 wires. There are 2 convergent K wires, like, and internal body. This is another method, but there is impalement of interosseous muscle in this procedure. Plate can be done, and this Faucher's bouquet technique. So this is done nowadays and with good results. So we'll slightly go into the technique of bouquet pinning. So this is the site of incision, and under image intensifier we make an entry point with a drill or a K wire. So a drilling is made, and once this is done, then this is very important. So here, this K wire, we bend it like this, and then we further bend it so that they go inside and they form like a bouquet, and we get a 3-point fixation. So this bend is used so we can hold the K wire and manipulate and go inside. And so once the hole is made, then we pass this K wire and try to get it reduced. And once it is advanced, so the K wire is cut flush so that we can mobilize the patient early. So this has been done. So this is a final positioning of reduction and checked on X-ray, and then we do the suturing. So these are few cases. This is an ENT surgeon, and he is a micro ENT, so he does that micro surgeries, and he wants that hand to be rested while doing his ENT procedures. So he came to us. We did this. So these are Shyam pictures. So we can see there is nice fanning out of the wires, and this is the band part. Now we'll cut it flush. So this is the final Shyam picture on table, and this went on to heal very well. He is having a good functional outcome. Few other cases, and here this is extended indication, like for the head of second metacarpal. So we did a bouquet pinning. This is another case. So sorry for the poor quality, but we can see here there is a lot of angulation. and this was treated with this K-wire. And we do immobilization for 2 weeks, and then we start mobilizing. This is an X-ray. This is so this is the angulation, and these are the things which is done. So here 2-3 things are being done. The wire were not cut. The wire is protruding out over here, and it is not fanning. And if we see, the wire is kept long outside. So these things should be avoided. This is not to be done in bouquet pinning, because we cannot mobilize, and there is the principle is violated. So in summary, 30 to 70 degrees of angulation is acceptable. May lose prominence of metacarpal head if we conserve it. Conserve is preferred. Avoid scissoring. Close reduction loss mostly. So up to 70 degree is okay. Loss of prominence of knuckle. Speak to patient about the pros and cons. Surgery, if it is more than 70 degrees, if it is open, again discuss with the patient. Thank you.
Thank you, sir, for excellent presentation, sir. I take a bit ulnar. I open through the ulnar aspect of the metacarpal.
Yeah.
This was a dead dorsal.
Yeah, dorso-ulnar. Dorsal.
Anyways, the extensor is quite a bit radial to this, so it is not injured anyway.
No, it is not injured. So we do open it at that point. We make a proper hole with a large size K-wire or a drill, and then we do this procedure. Any other question or suggestions?
What will you do for a malunited boxus fracture? Say after 1 year, what is the method of treatment? Will you do extension, close wedge osteotomy, or you, because some length is decreased by malunion, so you will just take up with a close wedge osteotomy, or you will do the osteotomy and put a bone graft and correct the angulation?
Sir, personally, I don't have experience of treating 1-year-old. In fact, you can put some light on it.
I am doing tomorrow. That's why I'm asking.
Samrat, any comments?
That's why I'm taking some.
Dr. Samrat, any comment? Dr. Parth, you can also.
Yeah. Anybody.
What about just opening up and not removing most of the soft tissues, and once you open the fracture site, reduce it, and
no, it is
attempt,
malunited.
only
1 year malunited.
Okay.
It's not a fresh fracture.
Everything.
So it is a malunited 1-year-old. Now patient came to me because he has got a problem because of the angulation, that extensor tendon is rubbing on the angulation. So pain is there on extensor aspect, and even in volar aspect, because the prominence of the head, he can't hold the things tightly. He's abutting on the object.
Well, the ideal answer is to put a plate, but I always feel it a bit dangerous thing.
Yeah, but
so,
how can you correct?
So if you put a plate, then you don't require a bone graft.
No, but see,
because
now the problem is what is the angulation. It's volar angulation plus shortening.
So as soon as you correct the the dorsal hump, that is, as soon as you correct the flexion deformity because of the volar combination.
No. Now fracture is healed. Just I want to correct that dorsal.
Yes, as soon as you correct that, the length will be achieved. Now the question is whether to put a bone graft or to. But if you fix it with a plate, you don't require a bone graft.
So if
you have that much space for the distal screws? That is the question.
No, see, if it is a volar angulation, and if I do a closed wedge osteotomy, like if you do in hip, you remove the wedge and put
It will further
volarly,
reduce.
and then just correct the distal fragment, is closing the osteotomy.
Yeah, it will further reduce the length. No,
But that's
it's
the
a volar
problem.
angulation.
Yes, that's the problem. So whether go clear cut osteotomy,
I think
correct
better
it
to
with-
do an open osteotomy and then fix it.
okay, then with the tension band.
Yes,
That
that's
can
what
be,
like I
yes.
was thinking, because plate will be too much. If you are
Yeah.
able to get a tension band, then
Hmm.
nothing like that.
Okay, because basically first I will do the closed base osteotomy and see the fracture. I will fix the temporarily with the K wire and see the length. If it is okay lengthwise, then I will put just the tension band. If it is not, then I will add a bone graft. What Ashok sir is saying, open wedge osteotomy. Well, already I am making a wedge, so I have got osteotomy on my hand. Or other thing is, can we use a bone pick from olecranon?
Olecranon or
Always.
even. Yes, sir.
You can use bone peg, na?
Yes.
Definitely.
That will solve the problem of your shortening.
Yes. That's why that's my surgical script in my mind.
Script. Great. Thank you, Dr. Vijay. So we move on further to our last talk for today. Dr. Parth Agarwal, he is a hand surgeon from Mumbai, and he will be talking on perilunate injuries. Dr. Parth, can you share your screen?
Yes, sir, definitely. Is everyone able to see it right now?
No, not yet. Yes.
Good evening, everyone. Thank you for good opportunity from IOA. Thank you, Ashok sir, and thank you, Dr. Vaigavkar sir. Today, I would like to present a topic on perilunate dislocation, which is most of the times missed by many of the surgeons. Nowadays, also, it is approximately 25% of the surgeons do miss perilunate dislocations. Let's discuss about it, perilunate dislocation and fracture dislocation. So most common form of wrist dislocation, the spectrum of the injury, which includes both ligamentous and osseous disruption. Yeah, mechanism and types of the injury are, it occurs when the wrist is hyperextended, ulnarly deviated, and leads to an intercarpal supination. As you can see in figures A, B, and C, where the wrist is hyperextended, ulnarly deviated, and intercarpal supination is being given in C. So now there are two types of injuries, the greater arc injuries and a lesser arc injuries. The greater arc injury is usually a ligamentous injury associated with the fracture of one or more of the bones around the lunate. Common pattern is trans-scaphoid perilunate fracture dislocation, fracture neck of the capitate, sagittal fracture of the triquetrum, and scaphocapitate syndrome that includes both the capitate and scaphoid fragments, which are devascularized by displacement. The lesser arc injury is purely a ligamentous injury, which is injuries around the lunate, disruption of the capsular and ligamentous connections of the lunate to the adjacent carpal bones and the radius without a fracture. Classically, a distal row dislocates in a dorsal or a dorsal-radial direction. A scapholunate dissociation or a lunotriquetral dissociation often persists even after the relocation, lead to a recurrence of the instability and late carpal collapse. Fracture dislocations are twice as frequent as dislocations alone. Now let's classify them. The classification, there are three types of classifications, but the most widely used classification is a Mayfield classification, which we have seen in our practice. It shows the progressive perilunate instability from a radial to the ulnar direction. As you can clearly see in the picture, The stage 1, where the distal carpal row is violently extended, supinated, and ulnarly deviated. STT and SC ligaments are tightened, causing the scaphoid to extend. As the scaphoid extends, the scapholunate ligament transmits the force to the lunate, which cannot rotate as much as the scaphoid because it is constrained by palmarly located radiolunate ligament and ulnolunate ligament, leading to a scaphoid fracture or a scapholunate dissociation. The next stage is a stage 2. If the extension, that is supination force, persists, then once the proximal row has been dislocated, transmission of the force distally to the capitate may lead to the displacement to the space of Fourier. As everyone of us is aware, the space of Fourier is a ligament-free area between the radioscapholunate ligament and the long radioulnate lunate ligament at the mid-carpal joint level. This is a potential area of weakness. Now, the stage 3, if the force persists, once the capitate is displaced dorsally, lunotricutal ligament also disruption occurs. Then stage 4, if the force continues, dorsally displaced capitate is pulled proximally. The pressure is applied onto the dorsal aspect of the lunate, forcing it into dislocation. As the palmar ligaments are much stronger than the dorsal capsule, dislocation never involves a pure palmar displacement. Note that the lunate dislocation is an end stage of the progressive perilunate dislocation. This is, in summary, how you can classify a Mayfield classification. The stage 1 is a scapholunate dissociation, which adds with a lunocapitulate disruption, which again adds to a lunotricutal disruption, which is also called as the perilunate, and lunate dislocated from the lunate fossa usually is volarly. It might or might not be associated with the median nerve compression. Now, through pictures, we can here very clearly see in stage 1, there is a scapholunate dissociation. This is also called as the Terry-Thomas signs, which we can see on the X-rays. The second is a lunate capitate disruption, with which you can see there is a scaphoid fracture. The third one, which is a lunotricutal disruption, is a perilunate dislocation, and the lunate dislocates completely in the 4th stage. Now, the clinical features, often a young male or a female with a high energy trauma, history of hyperextension injury, wrist pain, swelling, and deformity. The signs which are tenderness is distal to the Lister's tubercle. There is a marked prominence of entire carpus dorsally, and a compressive test is palpable. Audible snap can be seen. Click or clunk can be heard. The mid-carpal shift test is the test with which we can apply pressure over the dorsum of the capitate and wrist moving from radial to ulnar deviation. Positive clunk presence as the lunate reduces from the palmar flexed position. 1/3 of is associated with polytrauma. 16% have a median nerve symptoms and signs. Other features are ulnar neuropathy, also arterial injury or tendon disruption can also be seen. Late presentations causes increasing nerve symptoms or tendon rupture than wrist deformity, because to which the patient has often become accustomed to it. Now, investigations. Let's see an X-ray on a PA view and a lateral view. In a PA view, normally the anatomic axis of the forearm will pass through the head and the base of the 3rd metacarpal, capitate, radial aspect of the lunate, center of the lunate fossa of the radius. In a lateral view, as you can see here, the line will pass through the longitudinal axis of the index finger, metacarpal, capitate, lunate, and the radius with a scaphoid on a normal joint space between the carpal bones, carpals and metacarpals should be like this. Less than 2 mm should be normal. Greater than 3 mm should be a suspected ligament disruption, and greater than 5 mm should be a diagnostic one. Now, here are a few X-rays in which we can see a few signs, which spill T spot sign, which is due to palmar rotation of the lunate and disruption of the lunate. Capitate articulation, we can very clearly see this is an empty T sign and this is a spilled teacup sign. Now, the triangular appearance of the lunate is secondary to the rotation. As you can see here, it's called as the piece of pie sign. Now, the Gilliala lines, as every one of us are aware about, these are 3 arcs. The first arc passes along the proximal articular surface of the proximal carpal row. The second arc passes along the distal articular surface. The third passes along the proximal cortical margins of the capitate and hamate. So these are the 3 lines which we usually should see in an PA view, which are normally smooth curves. Broken arc is a diagnostic feature of the fracture or a dislocation. Now, in short, I'm going to discuss about DISI that is a dorsal intercalated segmental instability, and VC. So let's discuss about DC. DC is when the scaphoid is destabilized by a fracture or a scapholunate ligament disruption. The lunate and the triquetrum assume a position of excessive dorsiflexion. That is called as dorsal intercalated segmental instability. And the scapholunate angle becomes abnormally high, that is greater than 70 degrees, which is generally between 30 to 60 degrees. Now, we see when the triquetrum is destabilized, usually by the disruption of lunotriquetral ligament, the opposite pattern, that is VC, that is volar intercalated segmental instability, is seen as the lunate volar flexus. Now, greater than 60 degrees, this is the pattern which has to be seen on an X-ray, and less than 30 degrees, this is the pattern which usually is seen. The other method by which we can determine is carpal height ratio. Carpal height to the length of the third metacarpal, the normal ratio is 0.5. But if it is less than 0.5, it indicates a carpal collapse. Then a stress radiograph, like a clenched fist view, is to evaluate the widening of a scapholunate interval, often performed bilaterally. CT and MRI are to determine the extent of lesion and to know about the blood supply of the lunate and scaphoid. Now let's discuss about the management. There are, as everyone has non-operative and operative kinds of management. The non-operative kind of management, usually if patient comes early, we have a close reduction and casting. The indications are, no indications is used as definitive management. Outcomes are universally poor because functional outcomes with non-operative management. Recurrent dislocation does happen a lot of time. So close reduction is usually done by this method, like finger traps are elevated, elbow at 90 degrees of flexion, hand at 5 to 10 degrees of traction for 15 minutes. Dorsal dislocations are reduced by wrist extension, traction, and flexion of the wrist. Apply a sugar tongue splint if, or otherwise, if not reducing, then follow with the surgery. Now, operative management, emergency closed reduction, splinting, followed by open reduction, ligament repair, K-wire fixation, and possible carpal tunnel release. So, maximum of the times people do a carpal tunnel release. The carpal tunnel release is definitely needed post surgery. Why? Because it helps to relieve the pressure on the median nerve. The other operative that can be followed is a proximal row carpectomy, or the third option is a total wrist arthrodesis. It depends on the demands of the patients. Now, the emergency closed reduction splinting can be followed by open reduction, ligament repair, and K-wire fixation. The indications are all acute injuries which are less than 4 to 5 weeks old. Outcomes are emergency closed reduction. It causes decrease in risk of median nerve, decrease in risk of cartilage damage. Return to full function is unlikely because there is always a decreased grip strength and stiffness that are very common. The approaches are dorsal, volar, and can also be a combined approach. The dorsal longitudinal incision is centered at the Lister's tubercle. Excellent exposure for the proximal row and the mid-carpal joints, but does not allow us to release the carpal tunnel. Volar approach is always there to extend the carpal tunnel incision just proximal to the volar wrist crease. Now, pros and cons are both combined dorsal and volar approach we can use. The pros would be it gives us a dead exposure, easy reduction, distal scaphoid fractures, ability to repair the volar ligaments, carpal tunnel decompression. Cons are some believe that volar ligament repair is not necessary. Increased swelling, definitely. Potential carpal devascularization can also happen, and difficulty in regaining digital flexion and grip. Now, the technique: fix associated fractures, repair scapholunate ligament, protect scapholunate ligament repair, and repair of the lunotriquetral interosseous ligament. Post-op, the short arm thumb spica splint should be given, and it can be converted to a short arm cast at first post-op visit. Duration of the casting varies, but at least 6 weeks is the minimum time period which I apply my patients a casting. Now, the proximal row carpectomy is a technique in which we can use a dorsal and volar, both incision, dorsal incisions if median nerve compression, volar incision if median nerve compression is present. Volar approach allows to decompress it, and dorsal approach facilitates the excision of the scaphoid and triquetrum. Now, the complications in these are median neuropathy, nerve neuropathy have 29 to 45%, Chronic perilunate injury can also occur, and post-traumatic arthritis is bound to appear in 56% of people. Now, here I'm sharing a case. Around 23-year-old male. He presented to the hospital at 2 months after sustaining a right wrist injury from a motorbike accident in Cambodia. X-ray showed right wrist lunate dislocation and scaphoid fracture. Now you can see in this, the lunate is completely out. There is a scaphoid fracture and it's almost 2 months old. So we decided to go ahead and give him a proximal row carpectomy. So these are the intraoperative pictures. If you see, we have taken only a volar incision, but when we went inside and we saw the capsule, the lunate was just popping out of the capsule. We did an open exploration, right wrist, transcaphoid perilunate dislocation. We did a partial row carpectomy for it. And these are his post-operative images. Thank you.
Thank you so much, Dr. Parth.
Thank you, sir.
What is your protocol after post with proximal row carpectomy? Do you put K-wire? Do you put a slab? And how many days do you put slab or a cast?
So generally, I put a slab for first 3 weeks, sir. And then after 3 weeks, we do a casting for another 2 weeks. And after 2 weeks, we start mobilizing.
Okay. Thank you.
Right. So thank you all the faculty for coming and sharing and enlightening us with their knowledge and their preparation. At the outset, I would like to thank Dr. Ajit Shinde, Professor Dr. Ajit Shinde. He is President, West Zone, Indian Orthopaedic Association. And Dr. Navin Thakkar is Honorary Secretary, West Zone, Indian Orthopaedic Association, for allowing us. So for last 1 month, every Sunday, we are taking this webinar on hand and hand-related issues. The first week, we had mostly on the soft tissues. The second week, and this time it was fractures. So I thank Dr. Professor Ajit Shinde for giving us an opportunity over this platform. I also thank this OrthoTV, Dr. Ashok Shyam and Dr. Neeraj Bijlani for giving this platform. And this presentation has been broadcasted on OrthoTV as well as YouTube. Today, what we see is almost 385 members are there. They were present for this webinar. And once again, I thank all the faculty members. Any comments from anyone?
Very nice learning. And I think that we are almost at time, maybe 10 minutes ahead.
Yes.
Otherwise, we have done quite nicely.
Perfect.
Thank you so much. And thank you for giving us enough time. Almost everyone got 15 minutes.
Yes.
Thank you.
Yes.
Thank you so much, sir.
So, thank you.
Thank you, Ashok. Thank you, Ashok.
Yeah,
Thank you very
thank you.
much.
Thank you, Dr.
Thank you,
Vijay.
Ashok.
It was nice experience.
Thank you, sir. Thank you. Thank you all.